Hello, everyone. Welcome, bienvenue. Good morning, good afternoon, good evening, depending on where you're joining us from. My name is Jacques Rose. I'll be the moderator and chair for today's event. And I'd like to welcome you. I think we're going to go ahead and get started as we have a lot to cover in the hour and a half that's going to follow. I'm delighted to welcome you to the session From Promises to Action, Supporting Implementation of the WHO Global Diabetes Compact. I'm sure that many of you may have participated in parts, or if not all, of yesterday's Global Diabetes Summit. The intention of today's session is not to summarize all of this in 90 minutes, but rather dive more deeply into implementation and actions. Some of the things that really resonated to me yesterday were comments and quotes that this is just the beginning, that we must hold governments accountable to this incredible action, and that we need to involve future leaders and young people in our political process and policy, which is particularly touching for me working in the youth activities. So I don't want to reiterate all of the statistics because I think we heard them enough, but I want to mention just a few because I think they're important. The NCDs are on the rise and now make up 7 of the world's top 10 causes of death. Diabetes among the top 10 causes of death worldwide now, and has increased by 70% since 2000. The number of children and young people living with diabetes is also increasing every year, and 1 million now have type 1 diabetes. However, as we know, diabetes often goes undiagnosed or is only recognized when life-threatening complications develop. And for those who do receive a diagnosis, we don't necessarily have accessibility to insulin worldwide. So these trends are a stark contrast and contradiction to global political commitments to halt the rise of diabetes deaths by 2025. So this is me really just trying to set the stage for the discussion that we intend to have today. I'm really excited about the group of speakers that we have. We fall on a month that marks the 100th year anniversary of the discovery of insulin. And for the reasons I've just mentioned, a painful anniversary, as noted several times yesterday during the Global Diabetes Summit hosted by WHO and Canada, because of this fact that we don't have accessibility everywhere that we need it for this life-saving medicine, particularly as it relates to the story of the discovery of insulin and how it was intended. A few logistical items. I would like to really thank with all my heart the NCD Alliance and my colleagues at the International Diabetes Federation for setting up this session. A lot of work went in behind the scenes, bringing together all the speakers that you'll see today and you'll hear from, and we encourage you to participate actively in the chat. I already see a number of chat messages. I'm not going to be able to follow all of them during my moderation duties, but we'll do our best and encourage you to continue doing so. So thank you for that. 2 other items I wanted to mention was that we have a policy brief on diabetes and hypertension that the NCD Alliance, International Diabetes Federation, and the World Heart Federation has just published, calling for simultaneous action on diabetes and hypertension. We'll mention it again briefly towards the end, and we encourage you to have a look. We'll also be talking about the IDF Kids Advocacy Toolkit that will be launched on April 19th. But I don't want to take up too much further time. I have worked in diabetes several decades, and I've seen a number of initiatives that have brought great enthusiasm to the policymaking world. Yesterday, we heard from heads of state, we heard from CEOs of influential institutions and agencies making a difference in diabetes. And we heard from young people living with diabetes, and I applaud the WHO for the meaningful engagement of people with diabetes. I've lived with diabetes for nearly 25 years, and I think that that sets an incredible tone to what the Diabetes Global Compact intends to do. But I don't know if it's my Francophone side that still has some cautious skepticism that we must take action. And on that note, I would like to jump right in to the first panel, where I will hand over the speaking duties to Mark Barone, Dr. Mark Barone, my colleague at International Diabetes Federation, amongst other hats, where I've asked the speakers, given our time, to introduce themselves briefly, which is a big ask on my part because they have a wealth of knowledge and background they're bringing with them. So thank you for that. We will try our best to keep to time, so to allow for questions and answers for all of you. Mark?
Kyle, thank you very much for the introduction, for opening this important session. I'm trying here to share my screen. I think now I'm able to. So, and I would also like to thank NCD Alliance and IDF for the invitation to talk about this important participation of people living with diabetes in all the decision processes and tables, in order, to shape what we will build in terms of response to prevent and improve diabetes care globally from now on. So as Kyle mentioned, I'm Vice President of the International Diabetes Federation, and also a member of the steering committee of different organizations living with type 1 diabetes for 30 years. So I would start by mentioning that this is a unique opportunity, the 100 years of discovery of insulin. So I'm sure that Bente and Bess and colleagues would be happy to see the importance of their discovery. And, from one person receiving insulin almost 100 years ago to now more than 100 million people using insulin or supposed to use insulin, because at the same time that they would be proud, they would also, I think, be disappointed by the fact that half of people we estimate do not have full access to insulin or do not have access at all to the insulin they need. So this is why it is key and important to join together and to change this scenario. And for the first time in history, we came together, and WHO was key to give this opportunity to people living with diabetes, but also to public and private sectors to be consulted to design the Global Diabetes Compact in order to build resilient health systems, reducing the risk of diabetes and ensuring that all people living with diabetes have access to quality of care. But obviously, it is the intention, but now we need to keep working. And how? So we need to keep the sectors and the stakeholders working together. So from consultation to implementation and beyond. So as I mentioned, WHO opened the door, this beautiful picture of our informal consultation to people living with diabetes, more than 120 people engaged, most of them living with type 1 or type 2 diabetes. In 3 days, very intense discussion. And from now on, I suggest that we empower people living with diabetes everywhere, because people are not born knowing how to participate, how to actively contribute in the decision tables. So it is important that we empower them, make sure that they feel comfortable and they know how, when, why to contribute. And also to change the patient center, where people are expect to be patient taken care of, to an inpatient partner model, where people participate actively as part of the team, the health team, or even the policies team, the policymaker teams. And for the first time, we have now a strong document by WHO, the Global Diabetes Compact, that can be used everywhere as a tool for advocacy, besides the time, there is the insulin centennial that we use on, our benefit. And don't fool yourself. People living with diabetes are decision makers. They are not just storytellers. So allow them to participate. This is extremely beneficial. And my last message is an invitation to commit. We all participating in this webinar, respecting what Bente, Bass, and colleagues wanted to promote, to give the opportunity of healthy lives to people living with diabetes. And for this, we need to end premature deaths due to lack of access to diabetes care. So let's commit and work together on this. Thank you very much.
Thank you very much, Mark. If we could move along to the next speaker, I kindly thank you for your comments and hope we will get to the opportunity for question and answer at the end of the first panel.
Mr. Kyle Jacques Rose, Vice President, International Diabetes Federation, and today's event moderator. Dr. Mark Barone, Vice President, International Diabetes Federation. Dr. Bente Mikkelsen, Director, Department of NCDs, World Health Organization, other distinguished guests, members of the media, ladies and gentlemen all, good day. I would like to thank the International Diabetes Federation and the NCD Alliance for inviting me to speak at this timely and important event. I think this is a very significant conversation for Jamaica and the developing countries to be involved in. In fact, we are now seeing that the rate of diabetes in some developing countries have increased over the years. Diabetes has approached epidemic proportions globally. Diabetes rates in Jamaica, for example, are 25% higher than they are 10 years ago. As the rates have increased, the cost imposed on developing countries and citizens therein have also become quite significant, both in terms of direct and indirect cost. In 2018, diabetes represented the fourth leading cause of mortality among Jamaicans. It is estimated that 14% of all Jamaicans are currently living with diabetes. In 2018, it was estimated that 12% of Jamaicans had pre-diabetes with a higher prevalence among women, 13.3%, than men, 10.7%, putting them at high risk of developing diabetes. This means that 1 in 4 adults have or are at the risk of diabetes, and 25% of Jamaicans that have diabetes may not know their status. Given this immense challenge we face in Jamaica and in the Caribbean more broadly, I want to reiterate that I fully endorse the objectives of the World Health Organization Global Diabetes Compact as set out by the WHO, which includes harnessing the voices of people living with diabetes and providing opportunities for a variety of stakeholders to reflect on the content of WHO Global Diabetes Compact. Secondly, identifying and sharing lessons learned from government initiatives to improve access to diabetes and NCD prevention and care as a means to support implementation of the WHO Global Diabetes Compact. Implementation is a key element of the Diabetes Compact. There are some important factors that must be in place to ensure that this crucial part of the process is successful. Going forward, we expect to see greater emphasis on public-private partnerships as a means of improving both access to healthcare and the quality of our services for diabetes patients. Promotion of healthy nutrition policies, including front-of-package labeling requirements for the food industry, which will help people to make healthier food choices. Greater use of technology to provide comprehensive care, which includes screening and identifying those at high risk, referrals for intervention, and outpatient management. Citizen participation in the process and strengthening of community healthcare systems, and encouraging greater physical activity as well as behavior changes. Some of these implementation efforts are underway in Jamaica and in other countries. Despite this, We face challenges related to staffing, technology, and limited financial and technical capacity. There are also challenges related to a lack of community and self-management systems. In order to successfully implement the Diabetes Compact, ongoing support from the WHO and other stakeholders is absolutely critical. We must work together. In the first instance, countries that are challenged with maintaining access to essential medicines should be prioritized for financial and supply chain management support to ensure uninterrupted access to medicines. This is so important. Secondly, there is a need for technical assistance to fast-track the design and implementation of universal healthcare and national health insurance schemes, which can help to reduce or eliminate out-of-pocket costs for the most vulnerable populations. Support is also needed to increase the capacity of healthcare systems to detect, diagnose, and manage diabetes. Thirdly, the WHO and other stakeholders can facilitate learning exchanges between Caribbean countries and other countries with a similar NCD profile, as well as with countries which have had success in implementing major changes in their health systems. Technical assistance is also necessary for scaling up the use of information technology to deliver comprehensive care, diabetes prevention, as well as self-management and educational programs. In conclusion, I encourage all countries, developing and developed, as well as all our international, regional, and national stakeholders in the NGO community and the private sector, to make every effort to ensure that this very important initiative, the WHO Global Diabetes Compact, is successful. Diabetes is a global epidemic that requires a multifaceted approach that draws on our collective resources and talents to address both the prevention and curative dimensions of this formidable challenge. I stand ready to advance the goals and objectives of the Compact. Thank you.
Thank you very much to Dr. the Honourable Christopher Tufton, Minister of Health in Jamaica, for sharing your experiences from Jamaica and the Caribbean and beyond. Very appropriate comments. And my next speaker, Dr. Bente Mikkelsen, who those of you who joined yesterday's global summit would have had a chance to listen to. We are very thankful for your time, Dr. Mikkelsen, excuse me. We are interested in better understanding the expectations of the WHO of next steps to ensure successful implementation of the compact. The floor is yours. Thank you.
Thank you very much, Kyle, and thank you to the IDF and NCD Alliance for immediately following up and strengthen the engagement for the Global Diabetes Compact. So I'm very happy to see your impatience, Kyle, and I'm also extremely happy to see the importance of people living with diabetes and the reception this has actually gotten during the preparation of the Diabetes Compact and for sure in the continuation. I have 4 minutes. I will try to be quick. And I can assure you that I'm happy to co-lead this Global Diabetes Compact with all of you. And that is the whole idea. It's all hands on deck. It has to be a collective journey. And it's true that it started recently, but it's not totally true because it's 100 years since insulin. We have a lot of technical packages. We have best buys. So we have been working in the field for a while, but now it's time to really step up. And also, of course, as you know, we have set out 11 reasons to focus on diabetes, and diabetes, of course, as part of the cardiovascular disease area, as your publication so clearly puts. And it is a journey where we want to achieve and we want to demonstrate accountability and results in 2025 during the high-level meeting. And of course, we need to prove ourselves for the 2030. So thank you as well to the Minister of Health of Jamaica, Dr. Tufton. You summarized this so beautifully. Next slide, please. So our journey has been involvement so far, and I have not sort of built on all the work that has gone into this from people like Dr. Cherian Varghese, from Resolve to Save Life, from NCD Alliance. So I'm just looking into the journey for the Global Diabetes Compact. And you have seen that we have involved stakeholders, we have involved the Global Hearts meeting, we have had expert consultation, and very importantly, the first regular meeting with the private sector. And I totally agree, all hands on deck means really all hands on deck, including the private sector as well. Next slide, please. So we have set out a vision, and the vision is, of course, to ensure that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality treatment and care, and also to reduce the risk. So both risk reduction and treatment. And the objective is to protect, detect, treat, and recover. And I don't want to go in depth because this is a family of experts, but of course we need to learn and we need to utilize the horrible situation we are still in with COVID-19. I think this has been a wake-up call for so many governments, also able to listen to the voices from people living with diabetes and other NCDs. So we need to use this opportunity. It's a window of opportunity, and it's a one in a generation opportunity because of the 100 years. So the ask for partners is to unite, to really collectively be around the common agenda. It's to integrate, very importantly, to primary healthcare UHC. It's to innovate, and it's to close research gaps. Gestational diabetes was mentioned yesterday. We have many other gaps. And also we need innovation. We need to treat, improve access, we need to track, we need global targets, and we can learn so much from HIV, not only for the involvement of people living with, but also the need of targets that we can all understand and track progress and build accountability around. We need funds. And I'm very happy to see some light in the tunnel. I trust that the multilateral system actually is able to respond. Norway, Russian Federation, Denmark, European Commission has started to react very nicely on this. We need to educate health literacy, but also to educate people in the healthcare sector, and we need to power ahead and build back. Next slide, and I know my time is very much up, I guess, but the very premature architecture is important for you to see when you need to sort of think, where do I see myself in this picture? So we have a call for interest to a technical advisory group for diabetes. The deadline is the 30th of this month. We already have a partnership called Hearts, and this is very important because this is where we all meet together for cardiovascular diseases and diabetes. We have the people living with, and we also want to establish a forum for a multi-partner engagement. And we are looking for real commitments from the private sector, from the partners to come. And we have had some early front runners like the World Diabetes Foundation. Thank you for that. And we see a lot of interest coming towards the compact. Next, and I think that's the last slide. So at the moment, we have ongoing work streams, but this is something we want to shape together with all of you. But of course, access to insulin and devices is extremely important. And I mentioned some of the other things, and I don't want to go into more details, just mentioning that the humanitarian emergencies are important, and that whatever we do in the compact will also influence on the implementation roadmap that we are about to develop for the whole NCD agenda. So let's use diabetes as a sort of a front runner. Let's use the momentum, and let's do it together. So I think the last slide is a thank you. Okay, of course, it's the great leadership. So you saw it yesterday that we have many people on board, and I'm very happy to say that Dr. Tedros has really picked up this challenge and is supporting together with all the others and the ministers of health, heads of governments, and the people living with the disease. So thank you very much.
Thank you, Dr. Mikkelsen. And I think what really strikes me from what you've described, I expressed a cautious skepticism in my introductory remarks from my 25 years of living with diabetes and having seen many initiatives. But I really think that when we look at the amount of work that's already been done, that clearly was already happening, and the stakeholders you're involving from the field, whether it be IDF, NCD Alliance, World Diabetes Foundation, or otherwise, clearly there is a lot of work that's already been done. And that makes it, for me, more a cautious optimism to carry forward with this momentum. So thank you very much for your comments. I would like to continue with our next speaker, Mrs. Stefania Palomino from the Helmsley Charitable Trust.
Hello, everyone. Thank you so much for the opportunity, to the people from the NCD Alliance, the WHO, IDF, and society organizations. So today I just wanted to talk about how we are transforming promises to action from the philanthropic sector, and how we are supporting different initiatives to support people living with type 1 diabetes around the world. Next slide, please. Just for context, for those who are not familiar with the type of work that the Helmsley Charitable Trust does, our type 1 diabetes global access portfolio has 3 pillars. We focus on strengthening health systems, improving access to essential T1D medicines and supplies, such as insulin, and of course, supporting people living with type 1 diabetes as people, right? Understanding that and their needs go well beyond the disease. Next slide, please. So I just wanted to talk about a few exciting projects that tap into that objective of supporting people living with type 1 diabetes. One of them is our grant to USAIDF. And USAIDF is working to address food insecurity. So they partner with folks providing clinical care, and they tackle the challenges around food insecurity and livelihoods that affect communities in rural Malawi. Next slide, please. Sonia Naveta Foundation, which is a civil society organization located in Uganda. They provide insulin through their project Boda Boda. Access to insulin has been a major difficulty during the COVID restrictions and the quarantines. So the support that they provide by delivering insulin directly to the people who need it is invaluable. Next slide, please. Sante Diabet is also one of our newest grantees, and you may know Stefan Besson from all of our meetings in the diabetes space. So they have been working in Mali for quite some time, and now we are supporting them to provide technical assistance and more support for organizations located in West Africa. Next slide. And finally, we are continuously supporting the NCD Alliance. I think we all understand the value of the work that they're doing. Our Views, Our Voices is a very relevant project highlighting the voices of people living with type 1 diabetes, but not only type 1, also other diseases such as hypertension, other chronic NCDs. And putting people first in the NCD response is crucial to transforming this vision of the Global Diabetes Compact into action. Next slide, please. Also, taking these voices and these experiences to the mainstream agenda and showing, and we also the beautiful videos that came out of the Turning the Tide campaign, to showing these experiences to the world so that people understand that, again, we're talking more than about diseases. We're talking about people with families, with dreams, with hopes, that are often affected by more than one NCD. Next slide, please. And that's all for now. Thank you so much. If you have any questions about our portfolio, please feel free to reach out.
Thank you very much, Estefania. And I saw that one of the questions that came in during your presentation was about accessibility to insulin. And I think you began to address that. I know that it looks like it's also being addressed live in writing as well. But a former program of IDF, Life for a Child, which I believe Helmsley also contributes to and is contributing more to, is doing work in this for younger people around the world who would otherwise not have access to insulin. So thank you for that to Helmsley Charitable Trust. And thank you for your work. I've been told that we have exhausted our time for this first panel, but we will continue to answer questions live in the chat in a written format, as well as combine the Q&A with our next panel. So I would like to move right along for the sake of time. And it's my delight to introduce our next speaker, Ms. Jyotsana Rangeen. And as the chair of the working group for the IDF Board Working Group for Youth Activities, one of the major programs is the IDF Young Leaders that my working group looks after. And Jyotsana is a wonderful, shining example of an IDF young leader, and I look forward to your presentation. Please take it away.
Thank you so much, Kyle, for the wonderful introduction. My name is Jyotsana Rangeen, and it's such an honor to be here amongst all of you. And I want to thank NCD Alliance, WHO, and IDF to give me this opportunity to represent the young diabetes community. By sharing the needs and challenges of people living with diabetes, to be able to co-create a sustainable solution for others. We can move on to the next slide, please. When we talk about India, since I am from India, it's a small red dot on the world map, but when we talk about the number of people living with diabetes, it is huge. So currently 88 million people are living with diabetes in India, and it is expected to rise to 153 million in 2045, which is a very huge number. But it also talks about that it's just a tip of the iceberg in comparison to the challenges and inequalities that are present currently, especially in the developing part of the world. When we talk about diabetes in India, it is still considered as something which is self-inflicted, that you might have got because of sugar consumption, or probably it's something that your grandfather had and it is just running in the family, and then you cannot do anything to prevent it. Talking about these issues, amidst the myths and misconceptions that are prevalent in India, it is the need of the hour. It is the need of the hour to ensure that we educate people about the challenges and inequalities that are prevalent in India. Talking about the various challenges, the first and foremost is the availability and accessibility of insulin, which is a huge, huge burden and a huge challenge in India, where people are literally, they are surviving between the need of basic necessities and insulin. I've seen people in rural settings who are struggling to meet their ends, and let alone, take the burden of diabetes and to ensure that they're able to assess insulin and other essential diabetes supplies. Lack of national data registry exclusively for type 1 diabetes is also missing. There is no, healthcare system, adequate healthcare services that are provided. We do not have services available for people in rural settings, which is why it makes it even difficult to combat the growing challenges and epidemic of diabetes in India. Talking about awareness and education, which is majorly missing. So when I talk about insulin availability and affordability, RIA, Yes, we can move on to the next slide, please. I want to talk about Ria, this girl who braved the effects of diabetes due to insulin rationing. Due to unavailability of insulin, people are rationing their insulin, and because they're not able to afford this life-saving drug. And at one hand in India, the government of India is launching campaigns like for the welfare of children, to promote equal rights for children. But on the other hand, we do not have the availability of the life-saving drug to save people from their lives. So Ria was one such example. And because of rationing of insulin, she was not able to afford insulin, and she used to only take it once in a day, and which is why she landed into a severe complication where her brain swelled up and herniated into spinal cord, and she lost her speech and hand movement. That was a day when the doctor told that we might not know she would be able to survive for more than 1 week. But she fought hard because, of course, every person living with diabetes has the power, resilience, and strength as they're living with this condition. She fought hard and she came back. She met me in 2018 and she told me that even I want to grow up and become a young leader like you. Even I want to grow up and to be able to write and go to school, because she lost her hand movement and she's still not able to write and still not able to speak properly. So this is just one of the few examples that come in front of us, and there are many that we do not have information about. And there are many kids who have lost in this journey, in spite of celebrating 100 years of insulin. I think we cannot forget about the lives that we have lost because of unavailability and on accessibility of insulin in countries. Let's move on to the next slide, please. So understanding and talking about the various challenges and needs of children and young people of diabetes who are struggling day to day because of these unmet needs for their survival, and to have a chance to have a life which is free from stigma, discrimination, and also to succeed at every area of their life because we deserve it. When I talk about the challenges, the first and foremost definitely is affordability and availability of insulin, because we don't want another mother to go through the situation where she has to choose between keeping her child alive or feeding other children. We don't want that situation to have. We don't want another mother or another child to go through that situation. It is very important that we have awareness and education programs so that we can tell people not just take care of the diabetes, but in the best way, because just providing insulin is not enough. It's important that they know how to use it judicially. Timely diagnosis and screening is important so that we do not lose another life before they're diagnosed, and they're able to get the proper treatment and care towards the quality of life that they deserve. We also need allocation of funds in the national framework towards diabetes and essential care. That is very, very essential. And another important fact that we do not emphasize enough is the need to include mental and psychosocial impact, which is very, very important for people living with diabetes because they do not have access to such services. And it is important that this needs to be taken care of because it matters a lot for them to thrive better with diabetes and have a chance at life without the stigma, discrimination, and taboo that is prevalent, especially in lower and middle income countries. It's time that we provide quality of life with integrated healthcare by bundling up all the puzzles of diabetes complexity and by ensuring that we upskill the medical professionals to be able to provide the right care that we deserve. And it's time that we move beyond storytelling and end tokenism to involve people living with diabetes who have the power to use their skills, expertise, and lived experience to help co-create a sustainable solution and to help create an equitable, inclusive, and comprehensive diabetes care plan for all the people living with diabetes. We can move on to the next slide, please. So I want to talk about something which is very close to my heart. I'm part of Young Leaders in Diabetes program, and I think this is a wonderful opportunity and platform that is given to us who are looking for a platform where we can utilize our energy and passion and direct that towards a greater cause and towards the right path. It's important that we not only take care of the challenges and unmet needs of young people living with this condition, but also channelize them towards something which can help them to live greater lives for themselves and also make a difference in the lives of others by being part of programs like Young Leaders in Diabetes by IDF. And It's a wonderful program that does not only unleash the power of youth through patient advocacy, but also gives the right resources and toolkit to help you advocate better for yourself and for others. Thank you so much. To end, I just want to share one thing that, in today's time, it's high time that we end this issue of unavailability and affordability of insulin, and also ensure that we remove the tag of silent killer from diabetes, because we no longer need to remain silent, and we need to together as a unified approach break the silence and improve the lives of people with diabetes. Thank you so much.
It's been a fabulous experience here.
I don't let diabetes define me. I live my life. What?
I've learned so much, made mistakes, and I think I've become a better person now.
It's always great meeting new people, diversity.
Young leaders che mi programma, che sto ora che cante che dasse programme.
Congrès était vraiment spécial, vraiment joyeux, important.
Great opportunity to come together with so many like-minded people.
You can call me Pipi Langhaus.
Eu fico muito feliz de ter muitos jovens que querem mudar o mundo e fazer o mundo um lugar melhor.
Algo inspirador que te motiva a llegar al país con ideas grandiosas para implementar en tu comunidad.
Do diabetes advocacy.
Happy because I met with my friends, all the new ones.
It's really important for hundreds of millions of people around the world.
عندي سكر من النوع الأول وأنا مبسوط جدا إني معاكم.
Do something to make the world a better place for all of us.
Thank you, Kyle, for sharing that video.
Thank you, Jatsana, for those powerful words and shared experiences. I couldn't agree more. And for anyone who's interested in the IDF Young Leaders with Diabetes program, please contact IDF, as we will be making a call for applications in the near future, we hope. I would like to move along to our next speaker, Mr. Tom Robinson, co-lead of the global project from the Juvenile Diabetes Research Foundation.
Hello, everyone. My name is Tom Robinson, and it's a privilege to be speaking with you today. I'm here because I'm the co-lead of the global team at JDRF, Juvenile Diabetes Research Foundation. And I'm here today because I'd like to tell you some lies. Lie 1, type 1 diabetes is relatively safe. Lie 2, type 1 diabetes is a rich country problem. And lie 3, type 1 diabetes is just the little cousin of normal diabetes. Now, I say these are lies partly because I've heard the same stories you all have. Children going undiagnosed who never had a chance at surviving, young people who were diagnosed who struggle to make it into their 20s, and countries that think they don't have a type 1 diabetes problem only because their dead don't have a voice. But I also say these are lies because we have spent the last 18 months working together with the IDF, ISPAD, and Life for a Child to try and put numbers to those stories, to speak the modern language of data and analysis, and to give a voice to those who don't have one. And we call this shared project the T1D Index. And one of its strongest findings is that the humanitarian crisis in type 1 diabetes is in fact one of the biggest drivers of burden in global diabetes. Now, if that seems counterintuitive, give me a chance to make my case. Set aside the name diabetes for a moment. What if we told the world that there was an autoimmune condition that in the 90s had mostly been confined to a small number of people in a small number of countries, but in the years since, this autoimmune condition had grown quickly. Now, of course, we have fought back, developing new insulins, new delivery methods, new devices, and for some, living with diabetes today is better than it has ever been. And yet, at a global level, the picture today is of a world more burdened by type 1 than ever before. And yet even this picture is incomplete because it only shows those living with type 1. And yet here in the real world, we know that far too many are taken from us before their time. And if we count this population of missing ghosts together with the living, The true picture of type 1 diabetes looks like this: a fast-growing autoimmune condition that is affecting nations from DC to Delhi, and which is moving with cruel speed against the global south. And if we were foolish enough to fast forward another decade, we begin to approach the point where type 1 enters the conversation with HIV as one of the most dangerous chronic conditions on the planet. Now, you'll soon be able to access the T1D index yourselves and use this data not only at the global level, but for your country and your community and your people. And this information will help us to see the shape of the problem, to identify where the gaps are, to address areas of need, and to hold a mirror up to the world. We're going to do some great things together. But here, today, in 2021, type 1 is dangerous. For every 2 people living with it, we must grieve the loss of a third, a ghost who ought still to be with us today. And half these ghosts are being lost to us at the moment of onset, when an initial misdiagnosis becomes for them a death sentence. It's one of the greatest crises we need to address. And then the other half are lost because fully 100 years after the discovery of insulin, we are still sending our children to battle without the tools they need to defend themselves. Every time a child dies of diabetes, we lose 10 to 15 times as many years of life as we do when we lose an adult. Now, it is not a competition, but it's important context. It's one of the reasons why the T1D index tells us that this humanitarian crisis amongst children with type 1 is one of the greatest thieves of days in global diabetes, and should be, we would argue, one of our absolute top priorities as we prosecute this global compact together. Thanks for your time. Thank you for listening to my case. If you'd like to know more, reach out to us at t1dindex.org. And thank you for participating in this session today. This is important work that is going to benefit so many millions.
Thank you very much, Mr. Robinson, and thank you to JDRF for your efforts. I'd like to introduce our next speaker, Mr. Jewell from the UNICEF. Mr. Jewell, the floor is yours.
Thank you very much, and thank you very much to the organisers of this really important meeting. And it's been fascinating listening to the previous speakers. I mean, really passionate contributions about a really, really important issue. So thank you so much for giving UNICEF the opportunity to speak today. I'm actually going to be focusing on a slightly different angle, focusing on what we can do in order to prevent non-communicable diseases, including diabetes, through the work together as UNICEF, together with other UN agencies, governments, civil society organizations as well. So I want to cover 3 points in my short intervention. One is really framing NCDs as a critical issue for children and adolescents. The second is just to briefly touch on UNICEF's overarching approach to the prevention, management and treatment of NCDs, and then zoom in around our specific focus on prevention, including through healthy diets, physical activity, and the prevention of overweight and obesity. I think, as the previous speakers have already mentioned today, it is clear that NCDs, including diabetes, are a growing threat to children around the world. It clearly undermines children's rights to health, nutrition, education, and play. And the previous speaker mentioned the ghost, which I think was a really powerful way of describing the 1.2 million children that die from often treatable NCDs every year, including diabetes. And clearly, as the speakers have illustrated, this issue with NCDs is something that is present now in countries at all levels of income. And so we have to really move away, and I know we are moving away from this perception that NCDs are a high income issue to one that they're a global sustainable development issue. And I also really was touched by the point made about stigma and the experience of people living with NCDs. And that's something that UNICEF feels very strongly about as well, that children living with NCDs, or indeed the conditions that increase their risk for NCDs, such as overweight and obesity, often experience stigma, negative impact on their well-being. They can have difficulty with their peer relations, and it can undermine their learning potential as well. So really, this is something that threatens the development and well-being of children from many dimensions. As a result, UNICEF is increasingly advocating for greater attention to the prevention, treatment and management of NCDs in all the work we do. We focus on childhood, adolescent, but also the maternal years, because we see these as ages of opportunity where a significant impact can be made if we get our approach right. UNICEF's approach is a two-pronged approach, which cuts across not only health, but also nutrition, which is why I'm here, adolescent participation and engagement, and many other sectors. We focus first on early prevention. We believe that we must start with prevention because there's so much to gain by a focus on prevention. But of course, where prevention is not possible, we must also focus on the fair and just management of these chronic conditions through a lifelong approach. And that's something that we're really looking forward to scaling up more. A particular contribution that I want to speak to today, and that sits more with me as a nutrition specialist, is around the contribution that UNICEF can make to diabetes prevention through the early prevention of overweight and obesity. Now, this is clearly something that has been rapidly rising around the world over the past 10 years, and we see the fastest rise in low and middle income countries. More than 340 million children and adolescents are affected by overweight and obesity, and this is an issue that starts early. By the age of 5, we have almost 38 million children that are living already with overweight and obesity. What can we do about this? Well, the triple burden of malnutrition does make it somewhat more complex in that the countries that are battling this rise in overweight and obesity, this rise in non-communicable diseases, are still facing an unfinished battle with undernutrition, the wasting agenda, the stunting agenda, micronutrient deficiencies. So we need to bring those agendas together, but there are solutions. So just to wrap up, what we can do, we can focus on those double duty actions, including breastfeeding, getting early feeding periods correct, so that we get children on a healthy growth path. We need to work through different systems. So today there's been a lot of focus on what the health system can do, but I must emphasize that we need to work through the food system, education, and social protection to make sure that people can actually afford to eat a healthy diet. We want to focus on the effective advocacy for those policies that our colleague from the Caribbean mentioned, the food regulatory policies such as front of pack labeling, marketing restrictions. But then finally, we need to change the narrative. This is not about children's fault. It's not their responsibility, nor is it the responsibility of their family. This is a societal responsibility. And one of the most powerful ways we can do that is to engage the voice of children and adolescents themselves, as demonstrated so powerfully by a previous speaker. So thank you, and apologies for taking a little bit extra time.
Thank you very much, Mr. Jewell. I have been invited by the International Diabetes Federation and the NCD Alliance to moderate this final panel in today's session. Of course, on behalf of the World Diabetes Foundation, I express our sincere gratitude for the opportunity. The World Diabetes Foundation has been active for 20 years, supporting diabetes access to care and prevention in low and middle income settings. I have myself been part of the World Diabetes Foundation for the past 10 years. So I have been able to interact with ministries of health, national diabetes associations, and stakeholders across the diabetes and NCD space. And I believe we've seen a lot of progress at the country level and at the global policy level. So obviously, it is possible to progress, but we also know very well that progress is not going as fast as it must. And obviously, that's why yesterday was a very special day to all of us, and a day we will have to set as the continuing point of progress, but also the starting point of something new and scaled up. we would need to invest more. We would need to rethink the way we build partnerships in the NCD and diabetes space. And we would also need to scale up in many ways our contributions. And the World Diabetes Foundation will do so. We will commit to the Global Diabetes Compact, and we are actually already supporting directly the compact as it was mentioned by Dr. Mikkelsen. And we appreciate the leadership that Dr. Mikkelsen and the compact will give us all to unite into a joint scaled-up effort over the coming years. The World Diabetes Foundation will scale up its investments. The World Diabetes Foundation will open its partnerships, and also we will launch a new initiative very soon, focusing on health, digital health solutions and technologies. And of course, the way the compact has been explained, designed, and presented will help us all unite in a joint work stream in the fight against diabetes and its complications in the humanitarian response, type 1 in children, and the wider type 2 response as part of NCD responses. We saw yesterday unprecedented commitment from heads of states and ministries of health, and we saw how people living with NCDs have been engaged and will continue to be engaged. And we saw a range of international agencies and stakeholders very much committed. But I believe there's still one group which is very, very key to achieving our goals. And this group is the National Ministries of Health, the NCD departments, the technical professionals working in the countries, and the government's national NCD responses. And here today, we have 3 such representatives with us to give a contribution to this dialogue, but also to tell us all more about the perspectives from a Ministry of Health, NCD, a directorate or NCD department perspective. Where are we today with the diabetes response, and how can we achieve the goals we've set and by 2025 and 2030, and how can the compact help us with that? So we have 3 countries in our panel. We have 3 government representatives from Ministries of Health. We will start in Sri Lanka. So I'll pass on the word to Dr. Vindhya Kumarapelli, who is the director of the non-communicable diseases at the Ministry of Health in Sri Lanka. Please, Dr. Vindhya, the word is yours. Thank you.
Good afternoon, and thank you very much for your kind invitation to showcase some of the work done to increase diabetes and prevention and care in Sri Lanka. So Sri Lanka is an island nation with a population of 21 million, and NCDs are the leading cause of both mortality and morbidity in our country, and actually accounted for 83% of the total deaths in 2016. Where 10% were due to diabetes. And also according to the WHO STEP survey done in the same year, prevalence of diabetes was around 8%, but the rates are as high as 12 to 15% in urban areas. So our national NCD program operates under 4 main strategies. One of them is early detection and management of NCDs and their risk factors. The Healthy Lifestyle Centers were established way back in 2011 to support this. And there are over 1,000 Healthy Lifestyle Centers functioning at present, covering all primary care hospitals in our country. So people apparently healthy and 35 years and above are screened for NCDs and the main risk factor, including type 2 diabetes and obesity. So once detected with type 2 diabetes, they are referred to a medical clinic for further management, and those with pre-diabetes or obesity are offered lifestyle modification counseling. A personal medical record and a personal health number are issued to these clients to ensure continuity of care. And I also like to mention that the Sri Lanka Diabetes and Cardiovascular Disease Initiative, the SLDCI, which is the World Diabetes Foundation project in Sri Lanka, has strengthened nearly 500 healthy lifestyle centers, and around 350,000 people have been screened for type 2 diabetes. And doctors and nurses at these healthy lifestyle centers have been trained based on handbooks, flip charts with illustrations, on patient education, on early detection, healthy lifestyle, as well as insulin techniques. The second point I like to highlight is that in Sri Lanka, GDM prevalence is estimated to be almost 14% in 2016. So early detection and management of GDM was also supported by the SLDCI by training nearly 2,000 public health midwives and 500 doctors at primary care level. These doctors were trained on screening for GDM, pharmacological management, and medical nutrition therapy. The public health midwives, who are the grassroots level workers, were trained on encouraging pregnant women with GDM to follow the medication, medical nutrition therapy, and insulin as advised by the doctors. And these education sessions were done at the antenatal clinics or antenatal home visits and the postnatal home visits by the public health midwives. And our national NCD program collaborated with SLDCI, the Sri Lanka College of Surgeons, DFoot International, and conducted a food care certification program with hands-on training sessions. Doctors, nurses, as well as the public health nursing officers who provide home-based care were trained on prevention of diabetic foot ulcers and the relevant care services. Then establishing foot care multidisciplinary centers and setting up prosthetic and orthotic services was part of this. And by now, over 1,000 diabetic shoes have been successfully dispatched through these multidisciplinary centers. And the National NCD program advocates for expansion of cadres when required. As part of the SLDCI project, over 600 DNOs, that is, diabetes educator nursing officers, were trained on NCD prevention, early detection, and timely referral. These DNOs are stations at diabetic clinics at secondary and tertiary level hospitals. Considering the present COVID-19 situation, we have started training a batch of another over 300 DNOs who would be training online this year. And finally, to talk a bit more about health promotion and risk reduction, one of the strategies for health promotion and risk reduction is at selected settings in our country, that is schools, workplaces, villages, etc. So as one of the strategies, the SLDCI collaborated with the Ministry of Health, the NCD Directorate, and the Ministry of Education to create awareness and motivate teachers, children, and parents for healthy behavior. Here, the teacher-child-parent approach was adopted, and teachers were given tools to communicate with children in grade 1 and 2 more effectively, aiming a behavior change mainly targeting diet and physical activity. And this was done using booklets, storybooks, as well as posters, and these have been distributed to schools island-wide. To make this a sustainable project, the staff of the Ministry of Education were also trained. And I would like to end up by saying advocacy, leadership, and partnership is very important for NCDs as well as diabetes prevention and care. And SLDCI has been an outstanding advocate, especially for political leaders, and also being a representative at the government bodies of the National NCD program of the Ministry of Health, and has supported expansion of services for diabetes prevention and care in our country. Thank you very much.
Thank you so much, Dr. Bente. I believe, as I said in the opening remark, we should bring optimism and hope that things can be implemented and progress can be achieved. What you said now hopefully have given all of us hope and optimism that progress can be made. And of course, we as WDF, we are very pleased to have been part of a range of many stakeholders supporting Sri Lanka for some years. And thank you again for this wonderful statement, also highlighting healthy lifestyle centers and gestational diabetes among, of course, women, pregnant women, another very, very key aspect of our response to diabetes. We will move on to the next country representative, government representative, which is from the Middle East, from Jordan, where I would like to welcome Dr. Refki Mahmoud, who is the head of the cardiovascular disease prevention unit under the NCD Non-Communicable Disease Directorate of the Ministry of Health of Jordan. We know, Dr. Refki, that of course the burden of diabetes is high in the region of the Middle East. And we also know from a recent STEP survey done in Jordan that the data you have in front of you is calling upon more action on diabetes and other NCDs. And in addition to that, we are also seeing in Jordan and in some other of your countries in the region, the humanitarian challenge, of course. Could you please share with us your perspectives from Jordan, please? Thank you, Dr. Refki.
Well, thank you very much. I'm really very happy being with you, and I will thank very much for organizing this meeting, and it's my pleasure to participate on behalf of Minister of Health of Jordan. First, I will start what you finish, Dr. Bente, about the stepwise survey, which was conducted in 2019, the last stepwise survey in Jordan. I will talk about some data, some numbers. The prevalence of diabetes mellitus in Jordan in the last step survey in 2019 was 8.2%, which constitute about 320,000 patients for diabetes in Jordan. In addition to that, there was about 6.1% have impaired fasting glycemia. And also the study shows that 56% of the Jordanian never had tested their diabetes. And this is very important number also because of the lack of screening programs. Also, in addition, we found out that 18% of those who have diabetes do not take their medications. Even they know they have the diabetes, but they are not taking their medications. And also we found out that 11% of the people with diabetes, they are taking either herbal or traditional medicines. Also in other systems, we found out that the control of diabetes in Jordan is about 55%. And also from the mortality reports in Jordan, we found out that diabetes cause 6.9% of all deaths in Jordan, which is the fourth cause of death in Jordan for diabetes. Now, if we want to talk about the activities in Ministry of Health in Jordan, we strengthen our health system to provide universal access to essential health services, including diabetes care for Jordanian and for displaced population in need, and also for refugees, which we have about 3 million refugees, Syrian refugees in Jordan now, which constitute about 1/3 of the Jordan population. And also we ensure that diabetes care is part of our health system response plan for emergencies, with the mechanism required to deliver diagnosis, medicine, referral service, including for uninterrupted diabetes care. And also we establish and implement standard guidelines and procedures, as well as proper task-based training for healthcare providers to deliver effective diabetes care. Also, we ensure proper mechanism of data collection to document, monitor, evaluate, and continuously improve care for patients with diabetes while respecting patients' privacy also. Also, the Ministry of Health of Jordan is committed to providing permanent and continuous insulin supply to all diabetic patients. Also, the Ministry of Health is implementing a heart package, the protocol for heart, with cooperation of WHO for prevention, early detection, and management of diabetes and hypertension. That's what I was to like to say in this meeting, and thank you very much.
Thank you very much, Dr. Refki. It is still a sign of hope to all of us that you are able to progress despite the challenging circumstances, and if I heard you correctly, there was also a sign of commitment from the ministry and the government and the health system of Jordan to improve access to care, and even you said yourself, access to medicines, insulin, and of course, more than anywhere else, I suppose, or equally as anywhere else, the international community should be, of course, supporting Jordan and its neighboring countries given the humanitarian situation, which is actually also why I believe your statement here was of very, very high relevance to the way the compact and its goals have been designed. We might get back to you after the third speaker, Dr. Redgrave, with some questions as well around the context of Jordan, but thank you very much. We will move on to the third and final country and panelists today, which is from Ghana, from Sub-Saharan Africa. We have with us Ms. Elizabeth Denyo, who is the diabetes focal point at the Ghana Health Service under the Ministry of Health. Ms. Denyo, you have been engaged in the diabetes response in Ghana for a number of years. And now in your new, or you can say in your position as the diabetes focal point at the Ghana Health Services, could you please provide us some more insights and more perspectives about the response nationwide to diabetes in Ghana at the primary healthcare, of course, and how you see that in light of the compact that was announced and launched yesterday. Thank you very much, Ms. Denyo, for being here, and the word is yours. Thank you.
Hello, good morning. A very good thank you to the organizers, the International Diabetes Federation, WHO, and NCD Alliance for this invitation. Ghana, as a middle-income country, a low-middle-income country, have our challenges, but for the last 7-8 years, we've improved in our healthcare systems. We've made sure we achieving at the primary healthcare level comprehensive access and affordability to insulin to all those diagnosed with diabetes, so that diabetes doesn't become a death sentence. With that, we've partnered with Life for a Child Foundation, and for the last 7 years, we've been supplying insulins, strips, glucometers, and recently added laboratory HbA1c testing in some 13 centers scattered nationwide. Diabetes shouldn't be a death sentence. The Ghana Health Service is working hard with civil society organizations. In collaboration with Novo Nordisk, they've set up about 16 diabetes centers nationwide, which gives access to primary health care, access to quality and affordable care to those living with diabetes. At the same time, they providing technical support for healthcare workers and those living with diabetes to have a comfortable lifestyle. At the same time, we're happy as an organization working under the health ministry to be part of this global compact. We willing to commit and support anywhere that we can. At the same time, extending our hands to public-private partnerships so that we can move the diabetes care ahead. For now, we're looking at organizing workshop for health and civil society care groups, so that at least the normal person on the street will be able to understand diabetes, the causes, prevention, and how to get access to healthcare. What we're doing too as a ministry is to have a dialogue with the insulin producing companies so that insulin can be produced at a well as affordable price, so that people living with diabetes can also afford. We're working on treatment modalities, trying to get in foot care centers to be scattered nationwide so that people with diabetes complications can also walk through and have accessible care. So we in Ghana are doing our best, and we're hoping to be part of the Diabetes Compact so that we can help move the word out there and save lives.
I believe that was a very fine statement you concluded in your intervention here, Ms. Daniel, and I believe we have been in a very fast journey across three countries. Three Ministry of Health representatives have shared with us their views. We have a few minutes before we pass on to the closing session, and here I would like to go back to you, Dr. Bente, and just in half a minute or 1 minute, can you tell us a little bit on how will you foresee what is called a multi-sectorial collaboration in Sri Lanka? We know that there are many stakeholders engaged in Sri Lanka. It's not the ministry on its alone. Fortunately, you have built an alliance. Could you explain just for 30 seconds, who are you working with in Sri Lanka to make this happen?
Yes, Ben, thank you very much. The multi-stakeholder partners for NCD prevention and care includes the government sector, of course, the Ministry of Health, the Ministry of Education, Ministry of Urban Development, etc. But at the same time, we also partner with the professional bodies, the academic organizations for our technical advice, and most importantly, we partner with community-based organizations. There are well-established community-based organizations which operate at the grassroots level. We, of course, operate at the national level. So these community-based organizations have a huge network, well-established network with the villagers. So we plan to, in terms of multi-stakeholder partnership for NCD prevention, especially diabetes, we like to get involved more with our private sector organizations and community-based organizations. Thank you.
And please, thank you, Dr. Bente. This was exactly what I had hoped you would share with us. Dr. Refki, in Jordan, we also know that you are very much in collaboration with national civil society. Could you just share with us for 30 seconds or a minute, how are you actually managing to engage the national stakeholders of Jordan civil society and others, please?
Yes, thank you very much. Yes, Ministry of Health of Jordan, in collaboration with several NGOs and United Nations organizations are working together. Now, actually, we are working with RAS, with the Royal Health Awareness Society, with a lot of programs. One of the most program is the community health clinics, which are implemented in about 1/3 of our health facilities in Jordan, which we give health awareness and health education programs, and also screening programs and for the management of the diseases. And we found out that this is very, very good project, and it has a lot of impact on the patients and the management of the patients.
Thank you, Dr. Refki. And finally, Ms. Daniel, we knew last year the UN Interagency Task Force Award was given to the Ghana NCD Alliance. So supposedly the civil society is engaged in Ghana. And how is the Ghana Health Service and the ministry engaging to implement improved diabetes services? Could you just give us a final remark, 30 seconds, then we will move on to the closure session. Thank you.
Okay, thank you very much. The Ghana NCD office last year set up a platform through Path Ghana sponsored. What we did was all societies, NGOs, civil society involved in NCDs were brought together on a simple platform so that the government is aware of whichever NGO that is working in health, their projections, what they expect to do, their purposes. And on a single platform so that the government you can easily assess and mapping what this NGO is doing at a particular time. With reference to diabetes, for now, they are trying to put together data on those living with diabetes in the country, and then how to map and train level 1 healthcare givers so that they can easily identify those living with diabetes. We also started a program with pharmacists so that we put strips and glucometers at various pharmacies so that it could be a walk-in center for anybody living with diabetes or who suspects want to be diagnosed and just walk in for treatment. That's what we've done.
Thank you, Ms. Daniel. I think this will conclude the panel. We had 3 wonderful contributions from Sri Lanka, from Jordan, and from Ghana, which show us that a lot of work is happening. There's a lot of improvement possible. We can achieve the progress if we, as a global community and a national community, stand together. I believe Dr. Mikkelsen said all hands on deck. We see a lot of hands on deck, at least in 3 countries, and we know many hands are on deck in many countries. It's our obligation as the international community to support this, and so that we can reach the high-level meeting in 2025 and show that progress has been achieved. Thank you very much again, Dr. Refki, Dr. Vindya, Ms. Daniel, and Kyle, I'll give the word back to you. Thank you.
Thank you.
Thank you very much, Bent, and thank you for your contributions and comments as well as moderation. Keeping to time, thank you to the speakers with your insightful comments and experiences. I think we will just show a slide that I had made reference to earlier in the introductory remarks. I wanted to remind everyone of the policy brief on diabetes and hypertension put together by the NCD Alliance, International Diabetes Federation, and the World Heart Federation, which has been published. Please have a look, as well as the Kids Advocacy Toolkit, which will be released on April 19th, later this month. Let's jump right into Q&A. We have collected a number of questions we've been furiously trying to answer throughout the session. And I would like to perhaps draw attention to a few of the questions that I already saw answered in written format, but that came up in multiple occasions. And that is, we are getting questions from patient groups as well as other groups as to how to make sure they can be involved and incorporate all of what was discussed yesterday and in today's session. And I think what I would encourage you to do is we've posted a survey link that will allow you an opportunity to make the commitments that you would like to consider making. But I think if you feel like your group has not been included, or it's not clear how to be included, then I think that's really important that we discuss now, so we have actionable actions, for lack of a better term. So I want to put this out to the speakers more broadly, whoever would like to take it. How can a group that's involved in patient advocacy, for instance, as was the question from Veronica from Poland and Belgium, be involved, and what are the commitments they should consider making? I know, Dr. Barone, you made an answer. Perhaps you would be willing to take this question live, or others. I suppose I should have taken the approach of calling on one speaker in particular. I'll let you I'll have a think about that one, and I'll move on to another question. We've seen that with the COVID-19 pandemic, that governments and stakeholders have come together. It's been mentioned several times yesterday and again today, in a way that was very effective. We're still battling this, very much the case, but we have made an international collaboration, which I think is hard not to be compared to what we're trying to do in diabetes, very different disease states, of course. But the question is, how can we bring together our various stakeholders to have a similar outcome? What are the major obstacles to this? Again, open question to the speakers, please. Who would like to take it?
I think it's very important that you raised the COVID-19 challenge, Kyle, because if you look at the way the compact has been developed and the compact has been verbalized and the compact has been addressed, you can say, it's very much clear that Dr. Mikkelsen and all on board have taken very much into consideration, not least based on the survey that was done last year, which gave us some, I would say, frightening insights into the effect that a pandemic as COVID can have on NCD services, in particular diabetes and hypertension, but probably also Dr. Mikkelsen herself should elaborate.
So Kyle, can I take the floor?
Please.
Yeah, okay. So, first of all, I think I got some more questions that I was asked to answer. I don't know if you allow me, because unfortunately I need to leave too sharp. So, first of all, on the COVID-19, as Bente said, we did a pulse survey which really disclosed the huge disruption for people living with diabetes from the health system side. So during COVID, we saw that diabetes patients or people living with diabetes were more at risk of both getting severely ill and die. And we don't have excess mortality data yet at the global level, but we have seen this country by country. Then we have seen that delays in diagnosis, lack of access to insulin and devices, and the disruption was reported from all the countries, around 50%, and of course even more when they had a more severe part of the pandemic. So you will have seen that I posted the Pulse report. It's now a new Pulse survey that has just been done. So we will have new figures coming out in some weeks. I also want to assure you that WHO issued the guidance on how to continue care in the situation of the COVID and the pandemic, both on the community level and also in general. So these are available for everybody to look into. We also managed to change the strategic framework for response and preparedness to include something called Pillar 9, which is actually all the chronic diseases, which was not part of the pandemic sort of planning before. So that is sort of one thing. I had a couple of other questions coming my way as well on private sector engagement and also on silos versus integration. So it's up to you, Kyle, if you want me to comment on this before I unfortunately have to leave at 2 o'clock.
Please go ahead.
Okay, thank you so much. That's very generous. So there were questions on how to engage with the private sector. So actually the member states has mandated WHO to seek solutions to engage with the private sector. That happened already in 2011. And WHO have created a framework for how to engage. So we also take into account conflict of interest. So my department is leading on the pharmaceutical and device part of the private sector, and also related digital and can also be like insurance companies. So this is done from a technical point of view. So we had our first regular meeting now with the pharma companies and the medtech industry. And we will have a second one only focusing on diabetes. And in the first instance, we only focused on insulin and devices, because we have seen that every time we have tried to raise this, it has been deviating into, something very upstream, everything about health systems. So we need to actually address this very sharply. So you will see very quickly on our webpage a discussion paper on 31 asks to the industry to improve the access to insulin and devices. And we are now in dialogue with the industry, and we are seeing very, very nice signs of commitments, both on the pricing structure, on pool procurement, on pre-qualifications and so on. And hopefully we will be able to sort of get these commitments confirmed as quick as possible, I would say, but at least before the next meeting. So that's very important. Then, of course, we also partner with private sector, but it has to be done in a very certain way, because we need to be sure that we have a real management of conflict of interest. So we don't allow industry that engage with tobacco and with arms and things. You can read this, it's full transparency on that. So that's about the private sector, but we need all hands on deck. So we need to work also with private sector philanthropies, with academia, with civil society, people living with, and everybody. So we cannot do this alone. The second question was, are we now again, sort of, it was not put like that, but I'm sort of just saying it, I'm Norwegian, you know, so I'm simple. So are we now again creating a silo? And I would say very clearly, no, we are not creating a silo, but we are really taking into account, and for real taking into account, that people are living with and at risk of diseases. So the health system need to respond to the diseases. It's not enough to sort of just focus on health system as such, if it's not sort of linked to the real need of the people who are served by the health system, including healthcare personnel, education, health literacy, and of course, a very strong primary healthcare. We are not able to do this. So we are sort of moving through the diseases. Now we are discussing diabetes. Diabetes is, of course, super closely linked, as you have demonstrated, with cardiovascular diseases. So many of the deaths from cardiovascular diseases is coming from ill sort of or badly managed diabetes, as you know very well. So we are fully aware, of course, about the link, but still what we want to do is to really pick up the need clearly voiced by people living with and people at risk from diabetes, and to, through that lens, strengthen primary healthcare and include it in the universal health coverage. So there are many cross-cutting things, as you know, all the risk factors and so on in NCD. It's not that we put a cross over all of this. No, we are really taking all of this into account, but we want to be serving those in need. So that's sort of a clear message. I think that's what you asked me to comment on, and I'm very, very humble that I am invited to this meeting, and so happy to listen to all these extreme important knowledge and learning that is coming through the meeting itself. So please commit to the compact and let's do this together. Thank you.
Thank you so much, Dr. Mikkelsen. Thank you to all of the speakers who have taken generous time from their days to speak at today's session. An important one, and your last point couldn't be a more important point to end on as far as I'm concerned, to help those in need. We've heard about meaningful engagement of the community of people with diabetes. We've heard of nothing for us without us. The community must have a seat at the table, and the future generation, the young generation, must be part of this process. So I am more than cautiously optimistic. I am enthusiastic about where this will go, and I thank you all for your time and commitment to our cause. Good day, good evening,